We have a couple guests with us. Carrie Braithwaite from Children's Healthcare of Atlanta is going to be kicking us off with a short didactic presentation before we get into our case review. We also have Dr. Vaz Zavaleta is one of my colleagues at Children's Colorado. They got pulled into a case, so they may be a little bit late, but they'll be able to give us the IR perspective as well. So with that, Carrie, I will go ahead and turn it over to you.
All right, sounds good. As you can see my screen. So ultrasound and vascular anomalies. So this is just a quick run through. So I of course have to start with the ISSVA, which I'm sure a lot of you have heard about, but just in case not, I'll quickly review it. So it was founded in 1992, and it was a society that was formalized out of prior workshops. Had been going international workshops by Dr. Mulliken and Anthony Young, who have special interest in vascular anomalies. And the goals of the ISSVA are to promote the highest standards of care for the patients with the vascular anomalies and to encourage free flow of information through meetings and teaching programs, and to have this classification scheme that's really helpful, because previously, if you look in the literature, the nomenclature was all over the map, which made it very difficult for good communication and research. So I think the first classification was in 1996, and it's been revised a few times, and it's available on the website, and this is the first of many slides. So if you're not familiar with it, you should definitely check it out. So I got this little line expanded, but I thought it was a nice wording. This classification is intended to involve as our understanding of biology and genetics of vascular malformations and tumors continues to grow. So I thought that was a very good overview. So basically, what the ISSVA classification tried to do is separate things into two main camps, which is vascular tumors and vascular malformations, which I think is a very good way to start thinking about if you already have approached these lesions when you're imaging them. And a vascular tumor is like any other tumor, like a Wilms tumor. Like it's not there, and then it appears, and it grows like a tumor does. A vascular malformation is something that it's a malformation. So by definition, it's really there from birth or from fetal life. It's like congenital heart disease, and it grows with the child. Now, it's not always recognized at birth, which can be the tricky part, but it really should have been there since birth. Okay, so we'll start with the vascular anomalies with the vascular tumors, which is really probably the most common thing we see. And they break vascular tumors into three categories: benign, locally aggressive, or borderline, and malignant. And these are just one slide. Now there's three for these different types, and you can see these are the benign ones that goes on to the second page, and then these are the locally aggressive, and then finally the malignant. I'm really going to concentrate on, in the interest of time, the ones that we see most commonly, which are the infantile hemangioma, and I'll touch on congenital. All these other things, I mean, we do occasionally see Kaposiform Hemangioendothelioma, but they're pretty rare, and all these other things are pretty rare as well. So infantile hemangioma is super common. I'm sure you guys have all seen them out in the world, and in the hospital, both inside the ultrasound department and outside. They're very common. One of my kids had, I think, 2 of them. Clinically, they're supposed to be very soft. They can be variable in size. I'm sure you've seen, really tiny ones and really big ones. I think it's important to realize that the clinical color really depends on the depth of the lesion. I think that confuses a lot of people, and it led to terms like strawberry hemangioma, which we're not supposed to use that term anymore. But what we need to understand is that the color really depends on the depth. So the more superficial it is, the more red it is, and as it gets deeper, it can get kind of a more blue color, and then if it's even deeper, sometimes you can't even, there's no clinical color discoloration, so don't concentrate on the color of it. And what's key for this clinically is it has to have a characteristic postnatal growth pattern, which is sort of highlighted here. So basically, it really shouldn't be present at birth. Sometimes there's like a tiny dot, I think, like, I take a Sharpie pen, it's a tiny dot, but classically, the description is not there at birth. And then it starts, usually, you first start seeing it the first month of life, and then it rapidly grows during the first year of life, and it starts to taper around 6 to 12 months, and then it will slowly, very slowly go away. So what's really important is that when you're reading one of these, that you either know this history or that you follow it and it should follow this history. And I thought this was a really nice example because we see them at one moment in time on that curve. So I don't know why I keep going forward. So, but here's, baby, it's not there, and then you sort of see this little bit of discoloration, and then, and then it kind of peaks around here, and then in 3 years it's still there, but it's going away. So indications for imaging, the vast majority do not require imaging. That being said, we don't decide always who gets them, who gets an ultrasound, who doesn't. We do the ones that come in. So, but the reasons they always should be done is, the ones that are deeper and they don't have this discoloration and you can't see it, it may come to presentation later when the mom feels it in the bathtub or something like that. So they often come in and the question is, what is this? Any atypical lesions in eloquent locations, meaning that they're going to cause a problem by virtue of just where they are, like near the eye, multiple lesions, and then segmental lesions. And these patients are the big ones that have the big ones on their face or over their spine that can be associated with syndromic things, facies and lumbar syndrome being the two classic ones. So by ultrasound, they should be very well defined, very small, well defined. They're often in the subcutaneous tissues. They should not be intramuscular. They can be variable echogenic, variable echogenicity. They can be very bland, like this one. They can be a little bit more heterogeneous. There should be no calcifications. And I think this is something important to remember is that there should be no intralesional vessels on grayscale images. Like you shouldn't have like sort of the sonographic flow void by ultrasound. They don't have those. That's associated with other things. They're highly vascular, and usually the vascularity is very well distributed throughout the lesion and have a relatively low resistance waveform. I say the waveform kind of reminds me of the liver. So they do say, as they tend to go away, as they're getting smaller, the amount of vascularity can decrease when they're in their going away phase. But I don't think I've ever imaged one in that phase. So here's another classic one. This one probably didn't need an ultrasound, but makes for a nice picture. And this is the, like I said, we are seeing this in one moment in time. And ideally, we will get the whole history. But that's ideal and not always reality. So this is my standard dictation. I will say infantile hemangioma in the correct clinical setting, clinical correlation with clinical features, meaning it's soft, the age of onset, the growth pattern of time are necessary to confirm expected evolution and to consider follow-up with, say, the Vascular Anomalies clinic. So, like I said, it's like, I would say it's like looking at, being a helicopter and looking at traffic at one moment in time, it can change. So it really does need follow-up. So congenital hemangiomas are a lot less common. Again, the history is key. They're supposed to be present and fully formed at birth, and then they can rapidly involute, and we usually don't worry about things that are going away. They can not involute, or they can partially. Overall, the imaging is very similar. Rarely they can have calcifications, and then these are the ones that apparently can have intralesional vessels, seen on grayscale. So here's one. You can see there's a calcification, and you can sort of see that you can see these areas of the grayscale ultrasound vessels that you wouldn't see in a regular hemangioma, an infantile hemangioma. So these are the atypical features. Anything that's, kind of presenting outside the normal time period, certainly after 6 to 12 months, I've even read like 3 months. After 3 months, it really should have, come to attention. Anything that's painful or hard, it should not be hard. The word hard is always worrisome. If it doesn't have enough vascularity, it's like I said, it should be uniformly vascular. Spectral Doppler of a high resistance waveform, and then muscle involvement, lymphadenopathy, I mean, these things are obvious, and then calcifications, hemorrhage, or necrosis. So mimics, so here is a sarcoma, atypical. There's not a lot of vascularity. I would say it's also not very well defined. This is like, a more normal infantile hemangioma, and this one's, there's only vascularity around the periphery. Here's one of the infantile myofibromatosis. There's really actually almost no vascularity. Here's a sarcoma. not a lot of vascularity, and then you have a high resistance waveform. The most common sarcomas are going to be a fibrosarcoma, rhabdomyosarcoma that can mimic these. All right, so here is a case. It's a 25-day-old infant, has a mass on a wrist. That's what you're told by the ultrasound tech. So the question is, what do you want to know? The question is, do you want to know, is it soft or hard? When did it present, and what's its growth pattern? Well, this particular child, it was hard. It presented at birth and had doubled in size in 2 months, or 1 month. So that was an infantile fibrosarcoma. So when you have multiple, greater than 5, then you're supposed to do an ultrasound abdomen to screen for additional hemangiomas, liver being the most common site. You can get them in other places, although rarely. So here's a child. You can see, like I said, these are like the ones that you think about a little Sharpie pen. My daughter had one of these, and it was like, I said to the pediatrician, do you think that's a hemangioma? He's like, I can't even see it yet. So, but this one had, and then he had this liver distension, and then ultrasound followed by MRI showed multiple hemangiomas throughout the liver. Now I'm going to kind of turn the camp to vascular malformations. Like I said, these are like congenital heart disease. They're there from birth, and just like, you know, a small ASC or something may not be recognized till later in life. These don't always present, aren't always noticed until later in life, which is what makes them tricky. And then this is just to remind us what the hemangioma does and what the vascular malformation does. So capillary malformations, they're rarely imaged. You usually don't really see anything. They can be associated with other things, so sometimes we image them when somebody has one to look for things underneath, but usually not. The most common thing we're going to see is venous malformation. I tell the residents, like, really the only things you really need to know about, if you go with statistics, 99% of the time, if it's a vascular anomaly, it's either going to be infantile hemangioma or a venous malformation, so learn those for sure. So these are characterized by dilated dysplastic venous channels. They are also soft and compressible. The size really can fluctuate with gravity or activity. If it's in the leg, you know, when they come home from soccer practice, it hurts more. And I think what can be really tricky about these is they can often present, they're silent until the teen years, where the hormones make them clot more, and the clotting leads to pain. And so they come in with this painful mass, and nobody's really thinking vascular anomaly anymore because they're 14 years old. And that's when they, you know, people think there's something else, and we call them something else. And here's a classic one with the ultrasound and then the MRI. I think what used to confuse me is they can kind of come in two different camps. Like, they can be the very focal classic ones that we're all used to seeing, or they can just be like, this is more like in the syndromes I sort of think, like the clinical turnout, where they can just be like, you know, veins gone wild, like, you know, you have all these extra veins. So you can kind of get both. They can also involve multiple tissue planes, which hemangiomas don't do. They can, you know, be in the muscle, they can be in the fat, and they can even be intraosseous. So by ultrasound, I say they look like a sponge. With these, it looks like, and almost, a lot of people don't think they're vascular malformations because there's not a lot of vascularity, but they look like spongy, these big sponge, sea sponges. They can have phoebulus, but they can be hard to see. You have to almost like look at this and go, huh, I wonder if that's a venous malformation, and go looking for them. And remember, this was something I was confused about as a resident, that not all phoebulus calcify. Just because you're a phoebulus doesn't mean you're calcified. So I was always like, how come I can see the phoebulus, but I don't see anything on plain film? But if it does calcify, that's pretty classic for it, but really only the minority ones do. I've been told that the ones that are, that typically if they have a lot of calcifications, that means they have more phoebulus, which means they're probably more painful because they're clotting all the time. Low vascular density, you can get arteriovenous waveforms, also because sometimes they can be very focal, and sometimes they can be going into other, they're kind of going through the plane, so you might be getting something next to the lesion. And flow can also be absent if there's a lot of thrombosis. So here's a classic one, 6-year-old mass, left neck, stable since birth. You can see there's not a ton of vascularity, and then if you go through the cinae, sometimes you can find that calcification, which really makes you feel a lot better about it, and then, you know, you can get different waveforms. So some people talk about doing the compression and release maneuvers to enhance the filling of the venous channels. If you see something and you're not sure, you can do these things. You can put them dependent, again, you have to like make sure that you you know that the thought of a venous malformation came to attention. And then lymphatic malformations, we don't see too many of those. I don't know about at other sites, but we do see them occasionally. Obviously, the ones that are huge, like this, present at birth, but the smaller ones can present at any time, just like the venous malformations. They can, we say that the vascular malformations should grow with the child and shouldn't suddenly, get really big, but these can get suddenly bigger, and that's actually sometimes how they present, because they can either get infected or they bleed into themselves, and that causes a rapid enlargement that brings them to attention. And I would say that, like, this is how we often see them: is you have a child that comes in and it's like the mom's like, oh, well, there was nothing there yesterday, and now all of a sudden there's this big bump on their arm. And then you ultrasound it, and we've had sometimes people call them abscesses, but usually you can tell because there's not a lot of inflammation, but there'll be a fluid level, which isn't really shown here. The one thing that I've read to be worrisome about is that they're rarely unilocular. So if you just see one cyst, you should maybe think something else. And they shouldn't really have any vascular flow by MRI. They have a lot of fluid levels, and you can sometimes find that by ultrasound. There's a cute one here. The tissues are a little bit echogenic, which maybe it got infected or maybe it hurt, but usually you can see here it's pretty bland around it. This is a clot. They can clot too because of those hemorrhages, and that can make it look like a solid area. So if you look at it, when you think of a lymphatic malformation, you're like, oh, but this looks like something solid, which they shouldn't have. Put the dot on it to make sure that it is, actually soft, enhancing soft tissue and not clot. And then finally, AVMs. We don't see too many of these either, but they can present kind of late too. They don't always present in the neonatal period. So the key here is that that the teaching is that there's no mass; it's just vessels, and you have these. You can see the vessels on grayscale. Remember, the infantile hemangioma classically shouldn't be able to see that. Obviously, it's very, very vascular. Sometimes it can look like there's a mass around it because the tissues get very echogenic sometimes. If you sort of think about it like Crohn's disease, you get that fibrofatty proliferation of the mesentery in Crohn's disease. And I sort of think the same thing I don't know if that's the same etiology, but to me it makes sense in my head. Like Crohn's disease, you get that fat around it. So if you're trying to decide is that a mass or not, just kind of remember that. Because I've seen ones where people are like, oh, that can't be an AVM because there's a soft tissue mass, but it's actually not a soft tissue mass. And you can always, further delineate that with MRI as needed. And then you get these low resistance vascular waveforms. And here's one in this MR angiogram, and you can see that the waveform looks way different than the one for the infantile hemangioma. So how good are we at this? Well, imaging is never 100%, as we know. I always say it's like going to Vegas. We're going with the statistics. It acts like a duck, it walks like a duck, it quacks like a duck. It's probably a duck, but they need clinical follow-up. Make sure they keep acting like a duck so that we don't miss something that's atypical. And so you really have to have the imaging and the clinical together to get your answer. So that's it.
All right, thanks so much, Carrie. That was a really great overview. Really appreciate that. Let me go ahead and share my screen. I think that'll be a great jumping off point for a lot of the cases I have for us to review today. Let's see, our first case. So this is a little bit different. I thought this would be a nice case to discuss just today. Kind of a jumping off point for some of the things we discussed as far as kind of terminology and those types of things. So this is a teenager that came in with kind of right flank pain, had a renal ultrasound. And just incidentally, we had this liver lesion that was identified. So we recommended a contrast enhanced ultrasound to get another look at this. So I'll play through this clip here for you. So you can see the majority of the lesion is really non-enhancing. There's just really this kind of small dot of enhancement in the central aspect of the lesion. This is the second lesion that we saw when we went to do the contrast exam. You can see we're about 1 minute and 15 seconds in. It has a very similar appearance as that little dot of enhancement centrally, but largely the lesion is non-enhancing. Then kind of even later on delayed venous phase at about 3 minutes really has a similar appearance to it. So this has been described not in the world of contrast enhanced ultrasound, but in CT and MRI this kind of bright dot sign that we have called the so-called kind of hemangioma. I'm really kind of curious what you guys refer to these lesions as, just as far as nomenclature. I think that a lot of the literature and most of our kind of referring clinicians still think of these as hemangiomas. I'm really curious kind of how you report on these. We know that they're really not hemangiomas, they're really hepatic venous malformations. So how do you guys approach that? What do you kind of call these lesions as far as maintaining clarity, but also accuracy?
So I describe them as both because it hurts me to call it a hemangioma. So I'll call it either like an adult type hemangioma in quotes, and then say now classified as, I'll either say venous malformation or sometimes I'll say vascular malformation, depending who the referring physician is. Most of our children's referring people know what we're talking about, but occasionally we'll get like, a pediatrician that is maybe less familiar. So I try to give them both to be clear and maybe also a little bit educate at the same time.
Yeah, same. I usually describe it as a vascular malformation, but then in parentheses, will kind of be descriptive of like, previously known as like the hemangiomas and stuff like that. But I would technically call it a vascular malformation if it's outside of the, what Carrie described as like the infantile or congenital hemangiomas.
Right. Okay. I like that. And that's a nice segue into our next case. So this is a 3-month-old came in with all these skin hemangiomas. So this patient underwent liver screening for hepatic hemangiomas. So this was the initial liver ultrasound they had. It's some relatively more defined kind of more nodules in here, but largely not a whole lot of vascularity within those lesions. It's almost just kind of diffuse irregularity and kind of heterogeneity in the liver parenchyma. In a case like this, I'm curious in what scenarios you're okay with just stopping after the ultrasound and saying these are probably just kind of diffuse hepatic hemangiomas versus when do you go on to MRI to kind of further define these?
So for me, in the classic clinical situation, like we know that there's multiple infantile hemangiomas on the skin. If we have a nice history, then I just say multiple infantile hepatic hemangiomas and stop there. But I almost always refer to our vascular anomalies clinic, just like a quick blurb at the bottom, like for follow-up, basically to make sure that the patient is plugged in. Also, they need to do things that not everybody always thinks about. So infantile hemangiomas are associated with hypothyroidism. So I think that not just from the lesion itself standpoint, they need to get plugged into somebody who can, check everything that they need to check clinically with the child, and potentially, depending, on everything that's going on, consider treatment with propranolol. So.
Judy, would you recommend like just going to a contrast enhanced ultrasound as opposed to, jumping directly into MR?
Yes, definitely. But I think that if you know there are multiple cutaneous infantile hemangiomas, like that's the reason they got the ultrasound. I don't think you need to do the contrast enhanced ultrasound. Because it's especially if you don't see a primary tumor. So you're always going to see the suprarenal regions when you're doing your ultrasound. And so as long as there's no primary mass that we see, most likely a neuroblastoma or potentially Wilms tumor, but not typically at this young age. I don't. Maybe that's a little bit cavalier of me, but I just call them infantile hemangiomas.
Yeah, and I think that's a good point. I mean, I think the primary differential consideration for an appearance like this would be metastatic neuroblastoma. So I've seen that a lot of people do recommend screening of the adrenal glands with ultrasound. And then if they look okay, then you can definitely be more comfortable with calling these infantile hepatic hemangiomas. In this particular case, we did go on to MRI just because I think that just because they were so ill-defined and the liver was so heterogeneous, I think even in the setting of those cutaneous lesions that we just felt more comfortable getting an MRI. So have the image down here, you can actually see how big these cutaneous lesions were, and then just kind of just diffuse replacement of the liver. This kind of brings up another discussion point of what contrast agent you use for MRI. So you can see we use EUVIS for all of our liver MRIs. Do you guys have a preference as far as EUVIS versus something like multi-hands or another contrast agent?
I like EUVIS. And if you look at the adult literature, there's a paper by Claude Serlin where they recommend not using a hepatobiliary agent for possible hemangioma, but that's the adult type hemangioma, not the venous malformation, you know, the teenage age range and older vascular malformation. So I still really like to use EUVIS.
Yeah, same. I think anything liver related, I just kind of default to EUVIS. Did they, in the adult paper, because I haven't obviously read it, was there a reason specifically that they did not want EUVIS?
Because interpretation can be confusing, basically, since the venous malformation doesn't retain EUVIS, and so it can be confused for, you know, some sort of malignancy. Since they don't contain hepatocytes, it's not going to have EUVIS, and so that's the reasoning in adults. But you know, we know that it's these vascular malformations and vascular tumors, depending on the clinical scenario and what the lesion is. We know that they don't contain hepatocytes, and so we expect them to be not retain EUVIS in the hepatobiliary phase.
Yeah. Yeah, and this whole topic of which contrast agent to use just came up in our group recently, and most of our kind of liver experts really like using EUVIS in all of our liver, just because if you give EUVIS to, you know, in a case like this where it doesn't necessarily add anything, you know, it's worse to want EUVIS and not have it than the other way around. So you don't always know ahead of time exactly what the liver lesion is going to be. So their general preference is to always use EUVIS, and if it ends up being, you know, a case like this, EUVIS doesn't necessarily add anything, but if it ended up being something else besides hemangiomas, then it might have added something, which it's hard to know ahead of time. So we use EUVIS for all of our liver lesions. And then follow up on this case. So this patient was treated with propranolol. This is just showing you the 9-month follow-up that the liver is completely normalized, just very homogeneous now. So all of those lesions have pretty much just melted away at this point. So just a nice outcome for this particular patient. Next case, this was a 2-month-old that came in with a left cheek mass. So very typical appearance, like Kiri showed, of a hemangioma. So I'm kind of curious, just as kind of a next step question, do you guys, how kind of in the weeds do you get as far as trying to differentiate infantile versus congenital hemangiomas? You know, I think the most important thing, or the thing that I most heavily rely on is kind of the history, but I find that hard to get all the time. And then, you know, with the congenital hemangiomas where it's very clearly present at birth, I think we can be more comfortable calling those congenital hemangiomas. But, you know, a case like this where they, you know, it might be a deeper lesion where, you know, somebody may just have not noticed it for a couple months, but may have actually been present at birth. I find those a little bit harder to differentiate. So I'm curious, do you guys specifically say infantile or congenital hemangioma, or how do you approach that?
I think when I image them, and I always ask if it's decreasing in size or the same, because I feel like if it's decreasing, more likely it will be congenital. But I would, if I am really 100% unsure, I would just say like hemangioma, you know, either congenital if present at birth, and then just kind of like throw it back into the clinician's court or whatever, whoever that's going to be closely examining them. Or, you know, if there's like a increased growth pattern that's typical of infantile, then that's what it's going to likely be. But as far as like, do I definitely have to, I guess maybe the vascular malformation team will like enlighten us, but it seems like there's no true treatment unless it's really bothering them or too big, you know, like they probably won't treat all of these with propranolol or anything. So I'm not too sure if it really matters, I guess is what I'm saying.
I take a little bit of an opposite approach. I try. We all obviously don't get the best history all the time, and sometimes the history is not clear, even when we do have a little bit of history. But so I try to also distinguish if I don't have history, if it's solitary, that might be more likely that it's a congenital hemangioma. And also, I think the treatment is different. So the infantile hemangiomas, they give propranolol, but the congenital hemangiomas, there's typically not a treatment unless they need to like I wish that we had our interventional radiology colleague on, but you know, if they need to like embolize coil, do something because of the shunting of the congenital hemangioma. So if I can, I try to specify. It's not always possible, though. I agree. But I'll also just say that, like, this is the history I have. Based on this history, that's like, this is what I think it is, but you have to follow it, is what I'll say in the reports.
Yeah, and I think a lot of us are kind of spoiled if we work places that have vascular anomaly clinics, that we can kind of defer to them. We know most of these patients are going to get shunted through those clinics, but you know, I think if people are working places that don't have that clinic as a, you know, a quick and easy option to refer these patients to, I think I could see it kind of being a different approach and trying to be more specific. The other question I had for you guys was, do you guys routinely get waveforms on all of these? That, you know, we've talked in some prior sessions about kind of Doppler charges and whether that's warranted. You know, we know that, you know, these infantile or congenital hemangiomas, they can have arterial and venous waveforms. Do you guys routinely get waveforms out of all of these, or do you just get color imaging?
We do get waveforms, and I don't think we specifically charge for, you know, quote unquote Dopplers, but I think it just goes with any soft tissue masses. If there's blood flow demonstrated with color, then I think it's just an automatic reflex to get Doppler.
Exactly the same. And we're lucky that we don't charge. Maybe I shouldn't say lucky, but I don't think there should be a spectral Doppler charge for these, because I think spectral Doppler should be a part of the soft tissue mass evaluation for every mass. So we don't charge, and we do routinely do it for any soft tissue lesion.
Yeah, we take a little bit of a different approach. So we, like I said, we know most of these patients are going to get sent to vascular anomalies clinic, and they typically do more of the waveforms, and they're more kind of in-depth analysis. So our kind of primary role a lot of times is saying, is this a vascular anomaly or vascular malformation or not? Does it need to go to the vascular anomaly clinic? So when we do if the patient just comes in and they come into us just for a general ultrasound, we do color imaging, but we don't do waveform. But then they always repeat a point of care ultrasound at the vascular anomaly clinic, and they always get waveforms. So we kind of have a different approach, but I think that just works with our workflow.
Just to play the devil's advocate, then are there two charges, or do they is there a different charge for the point of care ultrasound that they do?
I'm not exactly sure if it's kind of rolled into their clinic visit, or how the charge happens on the vascular anomaly clinic side of things. But that's a good question.
Just always worry about like an extra charge for patients. But you guys have to charge as soon as you throw a spectral waveform on, right?
Right. Yeah, exactly.
So,
yeah. And the Doppler charge is not cheap. So it's,
yes.
in a case like this where it's not necessarily going to add something, then it's hard to justify, I think, sometimes.
Agreed.
All right. Next case. So this is a 3-month-old came in with the right thigh mass. So we can see this big lesion in the kind of subcutaneous tissues of the right thigh. Very robust vascularity associated with it. This was one that we questioned either congenital hemangioma versus a Kaposiform Hemangioendothelioma. So I'm kind of curious, like, what are your threshold for raising concern for one of those more aggressive lesions versus just calling it a hemangioma? Like, what are the imaging features that make you kind of jump to that?
If we know about rapid growth, I think that's most helpful. If you have labs of the consumptive coagulopathy, which we don't always have at the time of our ultrasound, unfortunately, that's also, those are associated with the Kaposiform Hemangioendotheliomas.
Yeah, those are the two things I was going to mention too.
All right. Yes, and then I'll show a companion case. This one, they just observed, they kind of mentioned, they saw our vascular anomaly clinic. They raised the possibility of both of those entities, either congenital hemangioma or KEH. But they elected to kind of just watch this patient. And this was 4 years later. So you can see there's kind of just this heterogeneity of the subcutaneous tissues where that lesion was, but pretty much just totally resolved. This patient did not get any treatment. On the other hand, this is a patient that had a biopsy confirmed KEH. So this was this forearm lesion. This was a 6-month-old, came with pain in the forearm. I can see kind of this heterogeneous lesion with this kind of robust vascularity associated with it. On MRI, you can see this kind of very discrete, kind of infiltrating lesion along the muscles and fascia of the forearm. This is one other question. This was, I've noticed that all of our point of care ultrasounds that our vascular anomaly clinic do, they always do these compression images. Do you guys do those as kind of part of your routine practice, or what kind of information do you get out of those compression images?
Yeah, I think we do that routinely with any kind of like soft tissue workup as well, along with the Doppler. And what do I usually get? Well, most of the questions are going to be like, is it an abscess or not? And so I find like that's helpful because it's more cystic, and then sometimes you can see the swirling debris as you kind of let go. As far as like vascular malformation, I think with some venous malformations, like you do get a little bit more of swirling or increased blood flow when you kind of release. And so I feel like those are sometimes helpful.
Exactly the same. I agree.
All right. Yeah, and I have a case example I'll show you of that later. This patient also had a good outcome. So this was 4 years later. So this patient was treated with sirolimus, and you can see there's still some abnormal enhancing tissue there, but most of the lesion is definitely decreased in size from that prior. So just a nice example of a KEH. So next case, this is a 10-year-old came in with kind of just soft tissue swelling over the eye. So ultrasound, we can see there's this kind of ill-defined, just kind of echogenic tissue over the eyelid. We have our right side for comparison here. On this image, you can also see there's these kind of hypoechoic channels in here. This patient went on to have an MRI, so you can see that kind of just this ill-defined soft tissue edema and enhancement. We don't really see those channels quite as well. You can see this patient also has some bone lesions within the adjacent calvarium. So this is a patient, there's a little bit of a diagnostic dilemma. Based on these channels, we were initially questioning whether this was either venous or veno-lymphatic malformation. This was one question I was going to ask Vaz about, and maybe one of you guys know the answer, but they took this patient to do sclerotherapy, and after the procedure, they deemed this to be a microcystic lymphatic malformation. So I think a lot of these, even after all the imaging modalities that we have to offer, I think they can still be a little bit of a diagnostic dilemma. So I'm curious how the kind of interprocedural findings really kind of affect what they diagnose these as, which I'm personally not super familiar with that kind of piece of this. Do you guys have any familiarity with that at all?
I think if it's veno-lymphatic, like if there's a venous component, you'll see the sort of flow, whereas a lymphatic malformation is just like each little, like pocket, if you will, of lymph. That's my understanding, but I'm not an interventional radiologist, obviously.
All right, and I have a couple other cases as well where we'll see this kind of just ill-defined increased echogenicity of the tissue. So this image right here is a pretty good look for the microcystic lymphatic malformation, but these other channels, I'm not totally sure how to kind of rectify that with what they ended up.
I think there is like a interventional radiologist on with their hand up, so maybe they can either
yes, I have to
Dr. Martinez
unmute yourself, but all right, yes, Dr. Martinez, thank you.
Hey guys, yes. You get me excited when you start talking about interventional radiology, but there is a very distinct diagnostic way we can diagnose these without doing the pathology. Once we stick the needle in, if we get blood return, it's going to be a venous malformation. When we stick the needle in and it's a lymphatic, we'll get more of a yellowish fluid, or if there's been a hemorrhagic process, it'll look like a rusty yellow fluid. So pretty much sticking the needle in gives us the venous lymphatic. And I haven't run into a lot of veno-lymphatic as may be referred to. You can have certain entities that are kind of clustered together, but when you stick your needle into one area, you'll get that return if it's venous. And then if you stick your needle into another area, if it's lymphatic, it will be lymphatic. So yes, then there's an angiographic appearance as well. With the angiographic appearance, just like you said, Squires, when it's a lymphatic malformation, it's just going to pull. When it's a venous malformation, it is always characteristic where you will see other little veins that are draining the venous malformation. It has a very pathognomonic appearance. So just wanted to add, I couldn't help myself.
Thank you.
Thank you.
Helpful.
All right. So next case, so this is a 6-year-old. This just kind of show you the classic appearance of a venous malformation. So this is kind of along the right thumb. I have some other images kind of up at the forearm level. So we can see these, like some of the cases Kiri showed, we can see these kind of dilated channels. We can see that they do fill in with flow, so it helps us differentiate between venous and lymphatic malformations, whether there's flow within those channels. Some of these areas do have thrombus within them, so we can see that correlate to this kind of thrombosed area on the MRI. So one other question I had was, not all of these channels typically fill in with color flow, either due to thrombus or due to slow flow that's not picking up color. We can see even where we do have color, it's very low velocities. I'm curious if in a case like this, do you guys try to differentiate either, like we just talked about, veno or veno-lymphatic? If you don't see color flow within some of these little cystic pockets, do you include a possible lymphatic component of that in your differential?
Yeah, this is where I would do the compressions. And then I don't know if you guys also use some kind of suburb microvascular imaging to see if it helps. Just to see if there's any flow whatsoever within it. But yeah, if there's no flow and then there's, vascular flow elsewhere, then that's when I would entertain both, probably not the entities together, but a component of lymphatic malformation with venous malformation. But sometimes just with the slow flow, you could probably try to elicit some kind of sign by compressing or using superb microvascular imaging.
Sure. And I think that when we scan these, I'm not sure that our point of care machines in the vascular anomalies clinic have microflow imaging capabilities. I don't see them do it a whole lot. We try to routinely do it when we're scanning these in our department, but that's definitely a good point. I think that would be a good technique to try to incorporate when it's possible. And then this is kind of just a companion case. So this is a 15-year-old that came in with thigh pain. So we can see, again, there's kind of this heterogeneous mass intramuscularly in the quadriceps region. We can see there is some flow within this kind of prominent vessel here that kind of communicated more superficially, but largely not a whole lot of flow within most of the lesion. I'll play through this little cine clip. So there's kind of this little ectatic vein more superficially that we can see does compress, but the rest of the lesion doesn't really change a whole lot. So this is we can see those fluid levels on MR, and then on the post-contrast images, we can see that kind of heterogeneous post-contrast enhancement. So this was just kind of a companion case. Just again, I think this nicely shows what that compression image is just showing. At least part of it is compressible, and then just kind of showing this ended up being a vascular or a venous malformation as well. All right, next case. So this was a 15-year-old. They came in with kind of this painful kind of thigh discoloration. So we can see that there's kind of this ill-defined kind of heterogeneous area, mostly within the subcutaneous tissues at the site of concern. We can see there are some arterial waveforms. There's really not a whole lot of discrete soft tissue. It's mostly kind of comprised of these dilated vascular channels. On MRI, we can see that there is this kind of just heterogeneous area of enhancement. Again, we don't really see a whole lot of deep extension to it. So I'm curious, this was one I wanted to discuss is, in a case like this, do you ever stop after ultrasound? Do you find that the vast majority of anything that gets called a potential vascular anomaly, do they pretty much always do MRI in those cases just to see the full depth of it? Or in a case like this where it's very superficial, do you guys ever stop after ultrasound and kind of proceed to management from there? Do you pretty much always do an MRI?
We do MRI a lot unless it's really focal and otherwise classic. But if you're unsure by the ultrasound how extensive it is, we usually go to MRI.
Yeah, I think we generally almost, for these, we typically go to MRI for most of them, just to kind of, I think there's a thought that ultrasound kind of can underestimate the full depth and extent of the lesion. So even in one like this where it visually looks pretty superficial, sometimes we see these like tiny little lesions that they'll do full extremity MRIs just to kind of make sure there's nothing else more concerning going on. But so that's kind of our practice. So most of the time these do go into MRI. Then this is kind of in the same vein. So this is just kind of showing the other end of the spectrum of how large and extensive these AVMs can be. So this is, I think this was the night pick up on this radiograph. So This patient was a 11-year-old that came in with new onset of thigh pain. So on the radiograph, you can see there's this kind of abnormal area of kind of cortical thickening. There's a couple little cortical lucencies in here. It's tough to know exactly what's going on, but recommended additional imaging in this patient. So on ultrasound, we can see these very dilated vessels in here. We can see some arterial waveforms. This patient did go on to have an MRI just to further define the full extent of this lesion. So again, we can see this is kind of very large heterogeneous mass, kind of this big tangle of vessels. We can see these big flow voids. This patient went on to have an angiogram, so we can see all of these very abnormal arteries kind of feeding into these very dilated draining veins. This patient ended up having this kind of P10 hamartoma syndrome. Again, this maybe is a question for our colleague, Dr. Martinez, if you're still willing to chime in. But I'm curious, in the setting of these kind of syndromic lesions, does that change how you kind of treat or manage these lesions? Or if this is just like an isolated AVM versus part of a syndrome, does that change how these are kind of monitored or managed at all?
I'm back. Yes. No, it's more about symptoms, and it's more about just making the patient comfortable. So if the patient is very symptomatic, we will do everything we can to decrease that arterial inflow. Of course, it's a little different for head and neck than it is for other body extremities. And I must admit that head and neck is my name of the game, but it doesn't matter if they have a syndrome or not. It's just more, how is the patient doing symptom-wise? And if they're having pain or evidence of the lesion causing issues, we'll go ahead and start doing embolizations.
Okay. All right. Thank you. All right. And then another kind of lesion in the same vein. This was kind of interesting, just how this lesion progressed over time. So this is a patient that came in with kind of this discoloration along the ring finger, had an ultrasound at that time. That kind of showed this kind of just ill-defined soft tissue thickening, but really not a discrete lesion, no discrete vascular channels. Patient wanted to have an MRI that showed, again, this little area of enhancement, but really not anything discrete. We often struggle with doing our MRA on these kind of very distal, getting good quality images, I think is very challenging. So we didn't really get a whole lot of information out of the MRA. This patient did go on to have an angiogram. We can see all these kind of early filling of draining veins. So we can see there is some kind of abnormal structure in the fourth digit here. So this was kind of initially thought to be related more to like a capillary malformation. So this patient was kind of just observed. So 3 years later, patient came back as we have more of a discrete lesion now on ultrasound. So we can see this discrete kind of ovoid hypoechoic nodule, very robust vascularity, some arterial waveforms in there. Repeat MRI showed that lesion had significantly increased in size. We got a little better images on our MRA at this point. So we can see MRA, we can see that the lesion is overall increased in size, and we can see that early enhancement on the arterial phase. So this patient, I think because of the small, kind of more distal location, we did not embolize this. So we did a bleomycin injection on this instead. And then patient had a follow-up ultrasound a few months later showing that lesion had completely resolved. So I thought this was just kind of interesting from the perspective of kind of how this evolved over time. I think with these vascular anomalies, sometimes they just take a little bit of time to declare themselves. It's when they're really small like this patient. I think it's just hard to know exactly what's going on with our initial imaging. But over time, we more clearly saw that this was an AVM, and we're able to treat that. Next case, this is just kind of a interesting diagnosis that we don't see a whole lot of. So I just wanted to share this with you all. So this is a 10-year-old came with 2 months of leg pain. So we can see on ultrasound, we can see this kind of echogenic mass. We can see some channels in here, some of which fill in with contrast or with color flow. On MRI, we can see that there's kind of heterogeneous enhancement of the lesion. We can see there's a kind of dilated cystic channels. This is a T1 image, so we can see there are some areas of fat within here. So this was a patient went on to have biopsy, and this was shown to be a FAVA, so a Fibroadipose vascular anomaly. So I think this is one of kind of the newer defined lesions within the ISSVA classification. So I think it's just kind of important just to be aware that this entity exists. So I think generally most of the time when we see these, they end up looking more like kind of have venous malformation type look to them, but they also have these kind of fatty components, this intramuscular kind of fat component on MRI. Clinically, I think these patients oftentimes will have pain, and they can develop contractures from this. So this was just a nice case that I wanted to share with of a FAVA, fibroadipose vascular anomaly. Next couple cases. So this is kind of a few different lymphatic malformations, just kind of show you the spectrum of these lesions. So this is an infant. So this is a fetal MRI. So this patient was diagnosed prenatally. So we can see there's this kind of cystic lesion along the medial aspect of the thigh. Patient had an ultrasound immediately after birth. That kind of macrocystic component had largely collapsed down. So we can see there's kind of this thin fluid-filled component, but then the overlying soft tissues are just kind of thickened and echogenic. We can see there's some kind of flow around it, nothing really within that more cystic component. This patient went on to have an MRI. So this is that kind of collapsed, more macrocystic component that's present deeper. And then the microcystic component along the more superficial subcutaneous tissues. So I thought this was just a nice example to share of a kind of combined macrocystic and microcystic lymphatic malformation that had a prenatal diagnosis as well. And then on the same spectrum, so again, this is more of a macrocystic lymphatic malformation. So we can see there's this large cyst with little scattered foci of debris in there, but kind of predominantly anechoic. Some of the deeper components, we can see that this is an MFI image showing there is some flow within the septations, but really no flow within the macrocysts themselves. An MRI, again, just kind of shows a similar thing. It helps us kind of better define the full anatomic extent of it. I think these head and neck cystic lesions can be a little bit tough just because depending on where they're located, there's some overlap with other kind of cystic head and neck lesions. This one, I think we were able to more confidently make that diagnosis of a macrocystic lymphatic malformation. But I'll show you another case in a second here of one that was a little bit more challenging. So this is a 3-year-old came in with new onset of right neck swelling. So this anatomically, this is a pretty good location for a branchial cleft cyst. But the overall kind of structure of it is a little bit odd. So we can see on CT that it looks like there's kind of 2 separate components to it. So there's this kind of more hypoattenuating component superiorly, this kind of more hyper attenuating component along the more inferior aspect of it. We can see on the parotid gland also looks asymmetric. So there's kind of this heterogeneity of the right parotid that doesn't exist on the left. So overall, we suspected this was probably going to be a lymphatic malformation, but went on to have both ultrasound and MRI. Ultrasound, I think, nicely shows why that more inferior component was a little bit more hyper attenuating on the CT because it looks like there's some kind of interlesional hemorrhage associated with it. Again, we can see some flow within the septations around the lesion, but nothing within the lesion itself. And then MRI, again, also just nicely shows that clot within the lesion, that inferior aspect of it. And then again, that kind of abnormal appearance of the right parotid. So Dr. Martinez, I have one more question. Maybe this is more in your wheelhouse being head and neck, but I'm curious, does the interlesional hemorrhage kind of change your management or approach? If you go to do sclerotherapy on this patient, does that affect how you can, what you do?
No, not really. That interlesional component usually causes a lot of pain. So we may put the patient on aspirin in order to kind of help break clot down as well as address the pain component. But no, it wouldn't change my management with sticking a needle in that thing and putting some medicine inside of there.
Okay, cool. All right. And then my last case, this was just a nice example, I think, of a little bit of a diagnostic dilemma. So this was a 9-year-old that came with kind of a new onset of a right shoulder lump. So on MRI, we can see there's this kind of relatively homogeneous, more solid looking lesion. On ultrasound kind of correlates with that, kind of in the right trapezius region. MFI imaging really nicely shows some kind of prominent vessels within the central aspect of this lesion. But this is one that it doesn't really nicely fit into any particular category on imaging. So it's hard to know, this is a venous malformation that just looks solid or, what's going on with this. So this patient actually went on to have a biopsy. So I think this is another example of sometimes we just can't fully evaluate these patients with all the imaging options that we have. And sometimes we just need to get biopsy to get more of a pathologic diagnosis. But biopsy did end up showing this is more of a slow flow vascular malformation. So I'm curious for you guys if you have had any similar scenarios, if you have, what influences your decision to biopsy these versus just making either following them clinically or
For me again, Jeff? For me?
Yes, please.
Okay, just making sure. So if there's anything that doesn't fit perfectly, so how I said sometimes we'll stick a needle in there, We're trying to see what fluid return when we aspirate. Say we stick something in there, we're not getting much with aspiration. If the imaging characteristics are not classic for a lymphatic malformation, which sometimes you, with your microcystic lymphatic malformations, you won't get any return, then we'll do a biopsy. So only if I'm 100% sure that's exactly what it is, like the low flow vascular malformations, I'll proceed with treatment. Anytime I have doubt or it's not behaving angiographically or by sticking that needle in there, I will take a small sample before proceeding.